George. Hmm.
St. George, Louisiana. Okay.
Tracy, I just sent it over.
Okay, just waiting on it to come through.
There's Blake. Morning, Blake.
Morning.
I have it posted, guys. I'm just waiting for it to update. They made a change to our database side of the website, and it just takes a little bit longer to update once I post it.
Well, for those on the call that don't know, we're not public yet, huh?
We are not.
Okay.
I mean, we are, but we're
We
not.
are
It's
on
not.
YouTube.
Okay.
Yeah, I just don't have the link posted yet, but it's
Yeah,
posted. I'm just waiting for it to update. Yeah.
if you look on YouTube right now, you can see it, Raymond. So we're technically public.
Thank you.
Sorry, guys, I have it published. I'm just waiting for it to update our website. It's just taking a minute. Okay, guys, it finally published. Y'all good to go. Sorry about that.
Thank you. All righty, I'd like to call this meeting to order. Please note any comments by the public are welcome and can be emailed to public@lsbme.la.gov. Jacinda, can you please verify the identity of all tele and video conference participants?
Yes, sir.
Is the sound clear and audible to the public and those on the tele and video conference?
Yes.
Yes.
All additions to the
Yes.
executive or public agenda must be made presently, as we will no longer make additions to the agenda after the close of the public session. Is there anything anyone would like to add to the agenda? We'll go ahead and close it. Diana, will you do roll call, please?
Yes, sir.
Sheila Guidry, Jim Lanahall, Diana Marandino, present. Blake Nolan,
Present.
present. Michael Nolan, Raymond Peasany,
Present.
Brett Stafford,
Present.
and then Dr. Hugo Azima. So we're missing two. And then from the LSBME, I have Tracy Morrow, Phyllis Johnson, Patricia Wilton, Lauren Soduth, Jessica Smith, and then somebody with the Zoom administration.
It's Jacinta.
Who?
Jacinta.
Jacinta. Okay. Jacinta. Thank you. All right, we have a quorum.
All righty. Is there any public comment, Jacinda?
Not at this time.
Okay, we'll go ahead and we've called the meeting to order. Introductions of participants and the audibility. I think we confirmed that everybody can hear us and they can speak. Did everybody find the agenda meets the criteria under the Louisiana statute? Ms. Wilton, I'll leave that to you.
Yes, it's correct. It's in order.
Okay. All right. At this time, we'll welcome any public comments. Jacinda?
There are none.
Okay. We'll move into the public session. We have the minutes of the previous meeting. Has everybody had a chance to review those?
Make a motion to accept.
I have a motion by Mike Nolan. Do I have a second? I have a second by Blake Nolan. Any discussion? All in favor? Aye. Any opposed? Okay, the motion carries. Ms. Wilton or Jacinda, is there any updates on rules and regulations that we've finalized? Oh, Dr. Van, I see he's there.
Thank you. I had a trouble. I was locked out. Freddie had to get me in. I apologize.
Any
No,
updates on the rules and regs, Doctor? Or Ms. Wilton?
Ms. Wilton,
No, we're still, it's still going through the process. We're awaiting any further response from the legislature, and we'll file our final reports and get them hopefully sailing through with no further discussion.
All righty. In your packet there, we have a correspondence regarding a vendor. And that is from Sarah Miller, and she is from St. Francis Health in Monroe, Louisiana. Blake, is this one of yours?
She is. So she's actually out ill today. I did ask if she would hop on for this one, but I can give, just kind of a summary. So the initial issue with this vendor was they have a methodology in their blood gas analysis that was producing results prior to a full error check being run by the device. And so what was happening is they were transmitting results or presenting results with these error messages that, per the manual, invalidated the result. And there was no way internally to suppress that result. So they were saying, well, your therapist has to make that determination. Well, some of these are fairly high level, beyond moderate complexity at the very least, determinations, which, per cap and CLIA, would require, if not an advanced clinical chemistry degree, a pathology degree. But I guess their argument was because the machine is describing the error, it's well within the therapist's scope to make that determination. And this all ended up being a little moot because we did find a way to suppress those results on our end with the error messages. But she had asked, and I thought, well, let me take it to the group because I don't know that I have all the answers for that one. is that creeping into, a clinical pathology area, making these, again, they fall outside of the scope of moderate complexity testing, which we do all the time, and they start falling into high complexity error detection.
Okay, I'm a little bit confused, Blake. So it's not the whole blood gas, it's one analyte, I'm assuming, or it could be two.
Sometimes it's multiple, but for the most part, yeah, these errors are coming across as one. And it's not your basic, air detected, clot detected errors. Some of these are interfering substances as well as, well, what they describe as an. Yeah, it's not something I'd seen before. That's why I thought it might be good to bring up.
Okay, so
my
let me, here's my dumb question. Okay, so all labs have to be CLIA certified. When these anomalies come up, what you're saying was previously you could not hide them. And when I say hide them, I mean
Yeah, suppress the result.
they got reported. All right. The question I have for you is when the anomaly comes up, the therapist should recognize that the machine at this time or the blood gas sample at this time is not reportable back to the physician. And we're holding that information back and running another sample until we get a confirmed good blood gas.
That is correct. The problem was they were asking us to make a determination, not simply an outright rejection, but a determination of validity, um, which is a whole different animal. And again, we made our own solution, and it's important to note this did not occur in actual patient testing. We have not gone live with a vendor, pending resolution on this and a few other issues. This is only in artificial sample testing.
I got one
Okay,
question.
Blake, let me ask you this. Is the erroneous value you're referencing, is that a beyond the reportable ranges where it flags
No,
it
it's
that
within the AMR. And that's why, if it's outside the AMR, I don't know of any uh, lab device that does not suppress that result. No, these are basically being flagged with, stuff that we would normally see, like a turbidity issue, detection of interfering substance like a lipoma or clot. Um, the issue I'm finding, though, is one, the error messages are somewhat vague. So my argument is, even if it is within the therapist's scope for that particular analyte, the message is so vague, you really can't ask them to make a determination. And again, it's kind of a moot point. We did find a solution to just automatically suppress those results between the time we asked the question and now. But again, it does vary between some of the electrolytes. We even see it on some of the co-oximetry, which is probably the most concerning. And again, the argument was, basically the vendor stating, well, that's up for the clinicians running the exam to determine. And I was like, well, I would argue that's not true. Um,
Hey, I did have one question from the beginning. Don't know which equipment you're talking about.
Yeah.
But the statement you had said something about, so they run the gas, they release the results or whatnot before there's this secondary run check or whatnot on the backside. So
yeah, and that's the issue. Basically, it is putting out a result before it's a final result. And so it is possible to result that without any error message being present at all until after you've transmitted to the chart. Now, again, we found a way to put a stop to that because that's just outrageous on their part. But
yeah.
I wanted clarification because they stated it's perfectly acceptable for therapists to make that determination on their own. And I mean, everybody can run their lab how they want. I don't want that happening in our lab. So we've found a way to suppress those results. But I just wanted to clarify if that was something anybody else had encountered or what the board thought. You know, I just feel like that's too high level of a
Okay.
function on some of these errors.
Okay,
Uh,
Sheila's next,
hey.
and then Mike. Sheila?
So my question is, y'all have found a way to suppress it and get around it, whatever, in your facility. But what about other facilities that have the same equipment?
That's why I wanted to ask the question. That's why I didn't just email and say, never mind, we found a solution, because I think
Right.
others may not, they may not have the same charting system we use, and they may not be able to suppress it in the same manner that we have without, you know, considerable expense.
Blake, that
Blake?
particular,
Excuse me, Mike.
Yes. Do you have a pathologist that oversees your lab?
So this is for the blood gas lab. So it's
Right.
a pulmonologist that oversees, and he was of the opinion that that was, frankly, a little bit iffy for his level of knowledge,
Yeah.
let alone, you know, our therapists.
Yeah.
And so
The
that was
reason,
his suggestion, was that would really be more of a pathologist question.
yeah, because they have instrumentations that may be having the same issue, and they need to suppress, and there may be some assistance
Dr.
there through the pathology committee.
Dr. Van?
Yeah, in her letter, and I'd like to clarify this because in the letter, it says that these invalidate the results.
Yes, per the manufacturer's manual for the device, results that have that flag should not be resulted. But again, the issue was they were basically presenting it as a final result, and then a few minutes later, we would get a modified result from the device after it had been transmitted. Now, again, we were able to shut that down before we actually took it live, which we still haven't gone live yet.
But
You know, I wanted to
still, I
clarify
agree.
this particular issue.
My concern is if nobody in the pathologist looks at these to determine if the invalidation is proper or not, you are going to be potentially resulting labs that the machine has said are invalid.
That's correct. That was our big concern. So what we did was we had to go outside of the vendor's normal workflow and basically from the back end on our end, suppress any of those results that had any type of error message, which is something we had done before, which is why I found it so odd that they claimed that we shouldn't.
So what do you do if you've suppressed the results and somebody's waiting for a blood gas? Run it again?
We do have to rerun that result. And it's
Okay.
not like it's happening a ton of the time. You know, we always, you know, every once in a while we'll get a clot or something like that, and that's easy to recognize. But some of these are, you know, more general, like interfering substance detection. Well, there's a lot of interfering substances and we may expect some, but that's not really a determination that we should be making at, you know, in a snap judgment at the bedside.
You know,
And do you have a protocol that says if you get 3 in a row on the same specimen, y'all don't result it and collect a new specimen? How do you handle that?
So we actually recollect after the first error detection.
Okay. Well, I mean, if you all are not resulting invalid results, but repeating the test till you get a normal valid result, I don't have a problem because you all are not making a clinical decision about the
That's
patient.
right. Yeah, and that's how we arranged it. But the only reason I didn't, you know, email and say, never mind, we found a solution for this is I'm concerned that other users of this product may be not even realizing that they're doing the same thing.
Well, let me ask you
Because
this.
it's not immediately obvious.
Is this some sort of widely held, universally accepted machine that's all of a sudden got some new wrinkles in the way it reports, that a lot of labs are going to have this machine? Or was this something that your institution bought, thought it was going to be good, and then didn't like it?
This is something that this was during the implementation phase when we were actually testing for transmission of results. It's a fairly common product. I don't know that it's very popular in Louisiana, but they're not a small market provider.
Well,
Sheila?
I think the thing to do is probably we ought to draft a statement a statement of position, maybe perhaps, that says if automated machines result, give invalid results, they cannot be posted to the chart and they should be reported to the supervising pathologist in the laboratory because, I mean, I don't mind you recollecting it, that's fine. And if the process in the laboratory is to recollect, that's great. The pathologist knows about it, it's okay. But ultimately, this 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 seems like they're doing this to protect themselves from some sort of liability, but creating liability for you all.
That was my opinion too, Doc. That was why I thought this needed addressing because it seems like they are off. The only other option we had, Doc, is if we could not find a way to suppress those results on our end, would have basically been to ask for pathological medical control every time one of those errors came up. And then that might have happened once a day. It might happen 3 times in one day. But I don't know of any pathologist who's willing to wake up in the middle of the night to make that determination on a
Yeah, that's
device that
gonna be a
shouldn't be
real
resulting in
problem.
anyway.
That's
Yeah.
gonna be a real problem.
Sheila?
Yes, I want to advocate for the patient right now. So what you're saying, Blake, is when you get one of these results, you will recollect another specimen and rerun it. So if the patient doesn't have an art line, you're going to have to re-stick this patient
That's correct. They would have to be stuck
because of a
again.
machine error.
Correct.
I don't like this at all.
Well, but that's a decision that the hospital made to buy that machine. That's a different story, but we still have to, whether we like it or not, the machine is saying the result is invalid.
Right.
And you're gonna have to repeat the test.
Yeah, you're going to have to. But
Yeah. And
So,
again, it's
Blake,
not like we're having a ton of these errors. It's just the way the device handles the errors that cause concern for me. They don't have any more. We're not seeing any more errors than we would in a normal workflow. Not probably 1 or 2 a week during that testing, which when you look at our volume is pretty good.
yeah. So you're saying you see that substance interference on more than one analyte that you're running?
It would depend on the interfering substance. Lipomas in this particular device's schematic basically invalidate all your electrolytes that you would run. Um, just the way the blood pathway works internally in the device. Because I really was going to try to take them at their word, and so I really dug into how it operates and how that might be legitimate, and I just couldn't find any justification uh, for that claim of theirs that, oh no, that's something a therapist can just decide. And I was like, not with the information you're giving us. At least not
And
within their scope.
And the other concern that I have is you said that you found a workaround that is not perfect manufacturer's recommendation. You can't find it in there.
No, so the workaround, they don't have a recommendation on suppressing results. It's just that there is nothing provided by the manufacturer to suppress that on the front end. So, and that's concerning to me as well, because the way the manufacturer initially had the devices set up, a therapist could see those invalid results come across. And now with our system, they can still see them, but they would not transmit to the chart because they have that error message attached. And so, which that's not a problem for us. Our policy is only what makes it to the chart is a valid result. We don't report preliminaries and we do not report from the device itself. We only report through the EMR. But that also creates the question, what happens when there's downtime?
On my calendar, but I have to, Hey, my Zoom thing, I can't raise my hand button, but one question I wanted to ask you on that, Blake, I know, is there a way on that particular vendor or whatnot to, I know my particular equipment does the same thing. It'll release results and then it runs another cycle afterwards for kind of a double check. And if it finds something,
and they all kind of do that. Our current solution does that.
so I have it turned off so it does not release the results. So it holds the results about a minute or two longer. why it runs that secondary post process.
Yeah, and that was part of our suppression solution. It now waits the entire cycle, which was irritating, for our physicians who were expecting a result much quicker than that. But again, that issue is when we go into downtime. I mean, you've probably run into this. We're going to run into that same issue. They're going to see that result, and it's going to be up to them to determine. Okay, it's got the error message. I should suppress it, which that is our policy. Any error message detected on there, it should not be resulted.
Should we, as a committee, recommend that suppression, numerous data, information should be reviewed by your pathology committee, pathologist? I would take it out of our hands and put it into the pathology group.
Dr. Van, I see you.
Well, my concern is that if you're gonna, and we talked about this earlier, and Blake mentioned it, it's 2 o'clock on a Saturday morning, and you're gonna wake the pathologist up and say, this is an invalid result. The pathologist is gonna say, repeat the collection and run the test. So, I mean, my thought is the only benefit that having the pathologist getting awakened enough times is that he might decide to change vendors and get a machine that doesn't do that, or talk seriously to the people and fix that problem. I mean, again, the real value is what are we doing for the patient, though? And, I'm like Sheila, I hate to see him get stuck again, but if the result is invalid, probably the first step ought to be just recollect the specimen. Now, if you get 2 in a row, maybe that's when you report it to the pathologist.
And we do have a mechanism, Doc, for what we call intractable errors like that, to get pathology review on there.
Well, maybe that's what we have to do is utilize your language that says each lab should have a method of dealing with intractable errors and consultation with the pathologist so that the decisions to properly report are not based upon an assessment by the technician, but by the pathologists themselves, and let this hospital put together the unique method of handling repeat contaminated or.
Yeah, because we'll all have different, command structures when it comes to labs. Some of us are part of the main lab, some of us are independent.
Right.
So yeah, I just wanted to get, some type of official input on that, because I have my own very strong opinion about it, but I wanted to make sure I was thinking correctly on that line.
Well, basically what I'd like to ask, Blake, if you would send a draft of what you think the policy ought to look like, and then Raymond and I will go over it with our lawyers, and then if we can get it done fast enough, either it'll be, because this committee can recommend, but the ultimate decision maker is the board itself. So what we would do is try and get a policy that makes sense, that Raymond feels comfortable with, you feel comfortable with, and if we need a quick meeting, we'll do it to get everybody on board. But if the committee empowers you and Raymond to do that, I'd be happy with that. And then once we get what we think is the proper policy, Miss Lauren and Miss Wilton can put together the document that we present to the board, and the board can then approve it, and we'll publish it on the webpage. And that's the only way you get an official statement.
Does the committee have any concerns if we follow that process?
I don't. The question that I have, though, is we can put it on our website and after you draft that official policy, but isn't this something that each of the labs would typically do under their CLIA guidelines?
They should have a policy for
there should be something that
rejection
would
of
cover.
policies.
And that should be
Rejection of
addressed in the
samples.
policy, and put that in the policy, Blake, and Raymond and I will do that. And then what we can do, we have the capability, and I'm happy to do it. Not only will we post it on the webpage, but we will send it to all of the licensed RTs in the state. And so they will know what the deal is. And again, I would like to avoid mentioning any specific manufacturer of a product, just in the
That's right. I haven't said any. Don't
Yeah.
plan on actually saying the
yeah,
name.
we don't want
No,
to
I
do
think
that.
Brad figured it out.
Oh, I know who it is.
I don't want to know.
I'm clueless, so we're good.
Okay. Well, we'll wait for Blake to develop that letter and send it to Dr. Collada and myself, and then we'll get together with the attorneys and look at it closely.
Will do. Thank
Thank you,
y'all.
Blake.
Thank you, Blake.
Mhm.
All right, we'll move on to item number 4, scope of practice questions. Willis Knighton Health. Oh, they got all
I
three of
just
them
like
in one
Dr.
line.
Hugo in.
Okay, thank you. Thank you, Dr. Hugo.
Hey,
All right,
Will.
we'll start off with David Miller at Willis Knighton. Basically, they started a pediatric transport team, and they have been asked, pharmacy has asked, they have asked if it would be within our scope of practice to verify only on transport with the nurse the waste of the controlled substance that's being given to the pediatric patient in transport.
I'm gonna say I don't have a problem with it. When you're on a transport team, you can't take 10 and 15 people with you to pick up babies. They're very limited, especially if some of these are in flight. And RTs are a part of that. Most of them don't send to nurses. Sometimes it's a therapist and a nurse practitioner that goes. And if they're following a policy like he just sent and they're midair and the nurse practitioner is going to draw up, just say morphine or whatever to make this baby comfortable during the trip, and needs to waste, I mean, I don't know who else is going to do it. So
Well,
I
and
don't
again,
have
all
a
I do is-
problem with it when they're transporting in part of a team and it's limited who you've got on the transport.
And again, all they're really doing is they're witnessing it. They're not doing the wasting. And as long as it's a hospital policy, they're following a hospital policy that allows for that. I don't think we should have a problem with that.
And they've come together. This is supported by their system pharmacy within Willis Knighton, and they've developed a policy for it, and they go through a orientation to be checked off and do a competency. And this is only during transports. This is not done within the facilities. Any other questions anybody would like to ask? So do I have a motion to approve this recommendation?
I move we approve the
Wait.
recommendation as stated.
Okay, do I have Blake, do I have a second?
Second.
Sheila, second. Any more discussion? I see Dr. Ugo. Do you have something you want to say, doctor?
I second.
Okay. Any further discussion?
Could you
All in
state, Raymond, could you state what we're voting on? What is the verbiage?
You want me to go for it?
Yeah,
Yeah.
go for it.
RTs during transport can witness wasting of meds. And then let me go ahead and put per hospital developed policy.
And those are controlled meds, Diana.
Yeah,
Controlled substances.
controlled meds per hospital policy. All right, so this isn't Diana jumping in the back of an ambulance at another hospital that has no policy and covering. Hospital has to have a policy and training. Training of transport personnel.
Any further discussion? Mike, did that answer your question?
Yes, sir. Thank you.
Okay. All in favor? Aye. Anyone opposed? Okay. The motion will be sent to the board for review. Dr. Collada, anything you'd like to add?
No, I think,
Okay.
if we need a little tune up, Ms. Wilton and Ms. Sudduth will tune it up and we'll put that on the agenda for this month's meeting. We'll get that done for you, for sure. And
Thank you,
Blake,
sir.
the sooner you get your stuff done, the sooner I can get it on the agenda.
Yes, sir.
Okay, the next scope of practice comes from Oshner Health. That's in your packet as well. And I'm going to recuse myself from any participation in this discussion. Sheila, I'll let you go ahead since you have seniority and run that question.
Okay, this is concerning, let me find it.
And please state the question.
Okay, they are reaching out to express concerns regarding the current respiratory therapy staffing shortages that they're experiencing. And they're asking to help alleviate some of this pressure. They would like to propose allowing their respiratory therapy assistants to perform specific non-invasive low-risk tasks, such as pulse oximetry checks, incentive spirometry coaching, and documentation. To ensure the safe practice and smooth communication, each respiratory therapy assistant would be assigned to a specific RT on that floor and would report all findings and patient interactions back to that RT. This structure would maintain accountability, reinforce patient safety, and support real-time decisions making by the licensed therapist. Allowing this would improve responsiveness to patient needs, reduce delays in routine monitoring, and support morale and productivity during staffing shortages. So basically, they're asking if these respiratory assistants can take on some extra duties from their therapist.
Well,
We've been here before.
yeah. Well, the assistants, the nurse assistants, are really, for lack of a better word, overwhelmed with more and more responsibility. And I mean, I don't know how receptive they're going to be to having more work put on them. It's not that big of a deal to take a pulse ox, but it does take time at the bedside for incentive spirometry. And not that they can't do it, it's just what else is being put on their plate. Has anybody checked with nursing service to see if this is acceptable? And this is at Oshner, right?
Well, the way I read the letter, it says that it wouldn't be a nursing assistant, it would be an RT assistant.
Right.
I'm sorry,
And-
missed that. Thank you, Doc. Thank you.
What are RT
Never mind.
assistants doing?
No, I think it's a valid point. That's why I went ahead and put the whole thing up on the screen. I hope y'all can see it.
Yes, sir.
We can. All right, I'm gonna play the devil's advocate here. All right. Oh, my RT directors don't beat me. This is what I'm looking at is who gets to bill for it. Okay. Number one, incentive spirometry coaching. I think that needs to be done by a therapist. Prior to going into surgery, coming out of surgery, whenever they get the incentive. I don't think now, can a nurse go in and coach on how to do an incentive spirometer? My answer to that is yes. Would I send my nursing assistant in there to coach and I shouldn't say coach, I guess initial instruction. But and again, I realize there are patients that are out on the floor that are basically low maintenance, got to stay for 24, 48 hours to be observed. But I'm thinking between the respiratory therapist going in the room, especially if the individual is on oxygen, they should be doing a pulse ox check. The nursing assistants are coming in and they're actually doing blood pressures and pulse ox checks. I'm not saying they're doing incentive. I may be different, but as if I was coming in as a physical therapist and I saw an incentive there, I'd want to know what they were doing with their incentive. And then nursing going into doing their things. I look at this as who's going to get the bill for it, not is this getting done, because I think pulse ox checks and incentives can be monitored by various different peoples throughout the day.
My experience, and I apologize for numerous, on several occasions being an inpatient over the last several years, incentive spirometry is given to me, but nobody's instructing me. And that's not just one facility, it's a couple of facilities that I've been in. The incentive spirometry, here it is, and they're gone. Nobody's telling me anything about it. Pulse ox, correct. Nursing assistants are doing it. The respiratory therapists are doing it. So we have that check and balance that going on, being performed. But the incentive spirometry, folks, here it is. Or in some cases, it's left with the patient admit kit. Nobody's telling me how to use it. And that's from a consumer. As far as billing, it's billed by the hospital. I get a charge for it. Not for therapist time, but for the device.
Blake, you have a question?
In most cases, that's the therapist time is built into the device.
Blake?
Well, I think as Diana said, the question of billing is pretty clear cut on CMS. We have our nursing assistants and other staff do pulse oximetry here all the time as part of routine vital checks, but that's not a billable test. Only licensed personnel are going to be able to bill those for the education and for the actual attainment of a spot check pulse ox. And even then, I mean, let's be realistic. I don't know of any insurer or payer that's going to actually pay for a spot pulse ox check. I don't know that I've ever seen it. They'll certainly put it on the bill, but as far as actually getting reimbursed, I doubt that ever happens. But pulse oximetry, that's already, done by just about everybody in the hospital. Frankly, I don't even know why they're asking that, unless they're asking if they could treat it as a billable, which of course they couldn't. Now, the coaching on incentive spirometry, I think we're pretty clear that needs to be a therapist. As far as, documentation that the patient is actually doing it, that I might be a little more vague on, but as far as the initial instruction, I think that has to be, a therapist.
Dr. Ugo? Dr. Ugo, you had a question?
There you go.
Yes, yes. I had myself on mute.
Okay.
I don't know if not if I know. I'm pretty sure I'm not sure what a respiratory therapy assistant does. Because it sounds I mean,
Valid question.
so like I've honestly, this is my first time even hearing of a RTA, a respiratory therapy assistant. So I'm not sure what they do, and if I can get some clarification on exactly what they do, that would be helpful because these seem like things that a respiratory therapist assistant could do, if just by the virtue of the name. So I'm curious if anyone can tell me what a respiratory therapist assistant does normally. Because if they can't do pulse oximetry and trip coaching for oximetry, I don't know what else an assistant to a respiratory therapist would reasonably be able to do. Like hold the medication while what I'm saying. Like
I
what
can, okay, now it's been years since I've been in the facility. At one time, they were assisting the RTs by cleaning and setting up ventilators to go. They did a lot of with the equipment cleaning and getting it set up. There was a time they could change out the oxygen device. The device was set up, the device was running, it was time for it to be changed. So basically, they took it down and they set another device up. And so they were used in O2 change outs, and those aren't going on as frequently as they were. The RT assistants stocked the units and stocked the floors for us. As far as our equipment that we had in our little closet. And then at one time, we had individuals, no, the RT assistants, I'm trying to think. And that was basically it. So, when they talk about this person being under the supervision of the therapist, is the individual going to go in the room, go, oh, he's on 2 liters of nasal cannula. Oh, his pulse ox is 96%. Are they going to report that back off so the therapist then documents it? And that's my thing about the billable piece of it is, are they, when they say they're going to be under supervision, so then is the therapist going to be able to put that in the chart and document it? Which again, Blake, even with the incentive, oh, I went in the patient's room, his pulse ox was 94, and I had him take 10 deep breaths on the incentive, and he was pulling anywhere from 300 to 600. Okay, that's a good thing. But now is the therapist going to document that? Because that makes it billable. That's where I'm having the problem.
Well, according to this, Diana, under their incentive spirometry, it says incentive spirometry coaching and documentation. So it sounds to me like the respiratory therapy assistants would be doing the documentation on that.
Yeah, that's what caught my attention on that.
Yeah, which
Okay, well
which I
then
don't like at all.
I just, again, when I was, we're RTs, and I'm with Mike. Sometimes they just give you an incentive and tell you to, here it is. You know how to take a deep breath on it. Okay, you're good to go. And individuals, like I said, when nursing comes in, they'll go, have you been doing it? I could lie through my teeth and tell them every 30 minutes. Some of them would tell you, well, let me see you do it. Others will say, okay, that you're good to go. I think it's crossing the line. And again, I'm looking at it. There's a lot of different people going in and out of that room throughout the day that could measure the pulse ox.
Well,
If
just
we
to be
were,
clear, there's no such thing as a licensed respiratory therapist in Louisiana that I am aware of.
Assistant.
Yeah, licensed
Assistant, I
RTA.
apologize. Please forgive me. Respiratory
Yeah.
therapy assistant. So they're not any kind of licensed phenomenon. We don't regulate them, okay? And so my concern is, this is a hospital-created position.
Mhm.
And I think, Ms. Wilton might want to comment on this. I think only the licensed person can do the work that's reported into the chart.
Yeah, I think it falls under the heading of whether this is considered an activity of respiratory therapy. If it's considered a respiratory therapist's activity, only a licensed practitioner is allowed to do that.
Correct. And I also want to go back to that, the sentence
Do you know where the
where it says,
path lab
help,
is in PBS? Can you go take that plug out of the UPS and plug it into the wall and see if that plug gas analyzer will come up?
Blake,
Because I
Blake, can
just
you mute yourself, please? Where it says to alleviate some of this pressure, I would like to propose allowing our respiratory therapy assistants to perform specific non-invasive low-risk tasks such as, so they have them, and she's calling them their assistants. So obviously they're already doing things which we have no idea what they're doing. That concerns me right there. Who knows what they're allowing them to do?
I just Googled the role,
Mhm.
and the thing that stood out to me is the line is, it is typically an entry-level non-licensed role that focuses on technical and logistical tasks rather than independent clinical decision making. And I feel like what this is asking makes it a clinical role. And if you're doing a clinical role, I think licensing is going to be required. And since it's not a licensed position by default, it might be a gray area that would require further clarification. I don't know if that makes sense.
Absolutely. Dr. Van?
Yeah, did I do something wrong?
No, just
I mean,
your opinion.
I still see the same thing. I apologize for not using the term assistant the first time, but they are not, they should not be entering into the chart. If it's entered into the chart, it needs to be by a licensed person in the state. Now, I want you to hear this. What's liable to happen, and if you play this out, is that somebody will come up with a licensed respiratory therapy assistant, and we'll be licensing them in a year or two. Okay, that doesn't bother me if it doesn't bother, but again, I think that may be where this is going to end up if it's such an important role in a hospital. I think this is just how do I want to say, a cost-saving measure to a hospital, and they're just trying to figure out how to use the cheapest person to get the work done. I mean, I hate to sound like that, but I think that's what it's about.
I do think it does sound like that there are things that they can do that help free up a respiratory therapist, especially if you have a shortage of respiratory therapists, such that the therapist can focus on higher acuity bedside clinical things. So like stocking, organizing, and tracking respiratory supplies, maintaining and assembling clean, disinfected and nebulizers, things of that nature. So there are roles that they can fill that can facilitate, making the respiratory therapist's shift a lot more efficient and less burdensome. So I think there's 100% a role for them if the purpose is to alleviate respiratory therapy burden. I think there's a role for that. I agree with you, Dr. Van, that it becomes a little tricky when it becomes a little bit more clinical, and certainly once they enter in the patient's chart, it becomes definitely challenging from a medical legal perspective.
I agree with you, Dr. Ugo. There are things I think they can do, but when it comes to actually performing tasks like this, I'm against it.
Sheila, you want to make a motion?
I don't know. Yeah, I just don't know how to word it.
Well, I didn't want to get one little piece of clarification. Like just about every hospital I've worked at, so they are entering pulse oxes as part of vital signs checks, and typically that is done by the CNAs. Now they're not licensed, but they are certified, and the Department of Health does have those standards of how often they need to work after certification to maintain the certification. They do have a competency evaluation that they have to take. So would that still be accept? But again, we don't have that for RTAs. I'm not aware of any like true structure for it.
No.
But would that mean also that we need to look at, I know, look at the MAs and the CNAs inputting pulse oximetry measurements?
That's a good question.
Dr. Van, I said I know I wouldn't participate in this thing, but just, because I was, do we think maybe we ought to have a little side committee of us to look into some of the systems independently and see what we can find out and what these students are really doing, and then bring it back to the board?
All right, again, I'm not sure if we're talking about students or assistants.
Well, they're respiratory assistants. Most of them are students.
Then that's not what this letter says, though, Raymond.
Yeah.
That's not clear to me, and maybe what
Yeah.
we need to do is we need to formulate a few questions, Raymond, you and I, and send a response back. We need clarification before we can give you an answer.
Okay.
I have a question. We mentioned students. Are these respiratory therapy students or respiratory therapy assistant students?
Well,
So,
first of all, I don't know who trains respiratory therapy assistants. So
right,
I'm not
right,
sure that exists, okay?
right. Yeah, that's my
But again, we have in the past, the hospitals have an opportunity to use students. And we expanded that during the COVID initial period when there was so much ventilator use that we let it happen that they could actually get paid. But these are generally people who, as part of their training, are working in a clinical environment, and they function as assistants to the respiratory therapist, but they're not licensed at all.
If I could add, the applications we have coming through, I do see respiratory therapy assistant when we ask them for an accounting of time, they have respiratory therapy assistant on their application.
Again, that is not a license for which we grant anything. That is a way of them showing what they did as part of their clinical work. But again, we don't license respiratory therapy assistants at this time.
Well, it certainly begs, as Raymond suggested, a little bit of information gathering. And to the extent there needs to be a public statement from the board relative to how unlicensed employees can be used in the practice of respiratory therapy, that's certainly something we could attempt to put together and bring to you all for your thoughts.
Sounds good to me.
All right. So we'll go ahead and collect some information. Raymond, can you help me find out how to reach these people and work with me to get that, or you feel uncomfortable doing that?
I can help you with that, doctor.
Okay, thank you.
Any other questions on this matter? Okay.
Okay. Thank you, Sheila. Is there any public comment at this time? I know that was a lengthy discussion.
Hang on, let me double check. I apologize. Not having it readily available.
There is none, Dr. Van.
Okay, thank you for that.
Okay, we'll move on to the FMOL letter. Let's see. We have a letter from Savon Sellers, the Allied Health Clinical Educator at FMOL Health in Baton Rouge. She's reaching out to request clarification regarding whether our Practice Act permits a licensed respiratory therapist functioning in the role of an ECMO specialist to administer blood through the ECMO circuit when clinically indicated. This process does not involve traditional IV administration. Rather, it entails introducing blood into the circuit under the direction of the attending physician. Beth Hover, Senior Nursing Director, contacted me with this inquiry as well. She has asked for verification regarding whether this activity is considered a non-delical task for nursing according to the LSBN, given that respiratory therapists are licensed profession. When reviewing the LSBN delegation framework for licensed personnel, respiratory therapists do not fall under the definition of individuals to whom nursing may delegate such tasks. Therefore, clarification specific to Louisiana is needed to confirm whether this function is appropriate and solely within the RT scope of practice when serving in the ECMO specialist role. If this activity is within the licensed scope of practice, we will proceed with updating our internal policies accordingly, and we are preparing for ECMO-trained therapists to perform blood administration via the ECMO machine and build competencies. I've included the AARC statement for reference, and that one should be included in your packet as well.
Okay. Can I give my 2 cents?
Go ahead,
Jump
Dinah.
right in.
Jump right in. Okay, so as an educator, let me just say we did not train our RTs for ECMO specialists because not all of our hospitals that we feed around here with our students had ECMO. At the time, we only had one institution. However, the institutions that have brought on ECMO as adjunctive therapy have utilized RNs and RTs to go for ECMO specific training to be an ECMO specialist. And so there's courses for that the individuals had to take. There were demonstrations that they could provide setting up the machine and all of this. They call them wet labs. And based off of the ESL standards, the individual has to be sitting one case every 8 weeks, or they have to go back for additional training. So they're running wet labs throughout the year for their personnel that are on the team. And I think what is here is the person, if I come in as the ECMO specialist, I'm not an RT. I'm not going to take any other work as an RT. I'm going to sit bedside and sit with that pump my entire shift. And so I don't, and when you set up the equipment to get ready to go, you're doing it under the order of a physician. A nurse can't order ECMO. The physician has to order ECMO. The physician would then, I assume, order the blood products. And then you set up the machine. You have to prime the machine before you hook them up.
What about an APRN?
Well, they may be doing it also. Depends on where they are at, who they've trained under. What I see here is physicians, but our licensure law says we can take orders from an APRN.
Yeah, so you would take an APRN order for ECMO.
Could.
Well,
Wouldn't it be a
again, I
perfusionist in
think
the context of ECMO?
I'm sorry, what was that, Blake?
Wouldn't you generally have a perfusionist in there priming everything for ECMO?
It depends on, I think, where you're working. I have a buddy of mine, RT, that went back to perfusion school. And, I was asking him, I said, so you use RTs for ECMO? He said, we use them at bedside in the particular area he's in. He said they would never go back into the OR, and where he's at, he goes, we usually put a perfusionist at bedside for the peds. Now he's up in Kentucky.
well, let's start. Their letter here says, their statement of policy from the AARC says, the respiratory therapist education provides extensive training in the maintenance of normal acid-base balance, oxygenation, oxygen delivery, ventilation, and cardiopulmonary anatomy, physiology, and pathophysiology. Okay, so that's a statement that we all agree on. Does anybody have any difficulty with that? Okay.
True.
Then equipment troubleshooting is another key attribute in the training of respiratory therapists. Okay, so are routine training components addressing ECMO now?
It's not, no, when you look at training and you look at troubleshooting, you're looking at it on the basis, I hate to say it like this, the basis of physics, blood flow, gas flow, circuitry, going in and out, passing through filters.
Yeah, but let me ask again, I'll make it simple. In your coursework where you teach, do you have an ECMO machine that you teach them how to operate?
No.
Okay.
No, and mine will not sit pump unless they go through the ELSO training. If you read the last paragraph, for us to do that, you've got to go get specific training for that specific machine that they're using.
All right, well, this sounds like it's begging for a rule change, okay? And basically what we're going to have to do is say, we're going to have to recognize that ECMO requires special training. We're going to, if we want to give a special certificate for ECMO, that's a different story, but only people who have specialized training in ECMO can administer blood on the order of a physician. Makes a little bit of sense, but I'm not sure we want even the routine RTs, as good as they are, to be administering blood, whether it's an ECMO machine or not an ECMO machine, on the order of a physician.
No, Dr. Collada, they're saying an ECMO specialist, and the ECMO specialist has to be in accordance.
Okay, to my knowledge, there is no recognized licensed ECMO specialist in Louisiana. Okay, so if we're going to say RT can be an ECMO specialist, we can say an RT licensed by us, who has a special training and certificate in ECMO, can administer blood, and that limits those. So if they took a perfusionist off the street, that's a different story. If they took a trainee off the street, that's a different story. Only the people that we're going to address this in the rules is going to be a respiratory therapist with special training in ECMO may administer blood on the order of a physician. That's a rule we'd have to add. And that way you would have the requirement of they're not just brought in, without ECMO training. Because it doesn't sound like ECMO training is part of the normal course work for respiratory therapists.
And again, it's not. We talked about back in the late 80s doing a perfusion program in the state of Louisiana, and there wasn't a big enough need to do that. But then again, in the late 80s, we in North Louisiana didn't even have an ECMO machine. I think the only ones that might have been using it was New Orleans, and there was only one, maybe two machines back then.
And most of them were in pediatric intensive care units.
They were, but the first ones that I used, or I should say that I came across up here, was done by our critical care specialty doctors in the MICU.
Right.
We did adults before we ever took on a neonate or ever took on a pediatric. But we were doing adults. Since then, they have added peds. To the best of my knowledge, we've never done a neonate. That gets shipped off, I think, back to New Orleans or Dallas or Little Rock.
Our standard perfusion, we license perfusionists, okay? That's part of their practice, okay? And so we have to be very cognizant of the fact that we know that's a license that right now ECMO requires a license through perfusion. And all we're going to say is we're going to expand the, if you want. I mean, if y'all don't want to do it, it's fine with me. My staff doesn't need another rule to promulgate. Believe me, we got plenty to do. But if you think we want to address this and say, okay, a respiratory therapist with special training can administer blood on the order of a physician through an ECMO pump, that's something we have to put in the rules.
Dr. Hugo.
Yeah, the whole ECMO process is such a complex, complicated setup that requires a lot of vigilance and a lot of care. I have two questions. What is the nurse doing such that a respiratory therapist has to be the one administering the blood? And two is, I guess, in line with what Dr. Van is saying, the is this within our scope of even allowing for us to allow respiratory therapists to function as ECMO specialists, quote unquote? Because I do think that does require a lot of training, whether that be internally or through some kind of certification. The ECMO is a very complex setup. And it's not just giving blood. So if you're giving blood and something happens, are you able to troubleshoot while all of that is happening? It's not something you just kind of start doing, if that makes sense.
And Dr. Hugo, I've never attended one of these courses. My students have gone and visited the wet lab as the therapists were being trained in this area. I would be more than happy to get you their training manual. It is extensive. This isn't go in and come out in an hour or 2 hours. And all I can tell you is respiratory therapists, again, have been doing this since I came out of school. And they just didn't throw them at bedside. And I'm one that came out of training that wouldn't even pretend I could go to bedside and do this. There's extensive training that goes on, and these hospitals, again, put those on with their staff. They do it, again, every so often. They have to get re-credentialed in it. And if you don't set pump for, I'm just going to say 2.5 months, you got to go through training again. And so it's not something I could be trained in January and then get my first ECMO in October and be allowed to go. That doesn't happen. So I agree. There's a whole lot of training, but I'm telling you, with this EL extra life support organization, they have set up a very rigorous training program, and I'd be more than happy to see if I can get that.
Is that
one of my two
licensed?
institutions.
They're on board. Who's their license through ECMO?
There is no official licensing of ECMO technicians in the state, to my knowledge, Michael.
Okay.
Perfusionists do it, and we have a number of perfusionists in Louisiana. Excuse me. This seems to be begging for a rule to allow it, and we have to figure out how to do it safely if we're going to pass a rule. If y'all don't want to pass a rule, you don't think they should, even with, my thought is, you're telling me that there are respiratory therapists who have undergone training and are doing this. And my feeling is, if they've undergone the training, they're doing this, then on the order of a physician, they ought to be able to do it, but it would have to be a rule we'd have to put in. Ms. Wilton, do you agree with me about an addition to the rule?
Yes, I do.
Yes, because we have ECMO specialists at almost all the bigger facilities. You know, Ochsner has them, the Lake has them, Ochsner up northern part of the state. I think Willis Knighton may do
Willis
some.
Knighton has them.
Yeah. So this is nothing new. These people have been in place.
Now, again, I'm thinking that, we're not going to create a new license class. We're simply going to say that a respiratory therapist with credentials and training in ECMO can accept, and is doing ECMO, can accept an order to give the blood. We're not going to create a new license class. We're not even going to create a certificate we're going to track, okay? Unless you think we should. We're just going to we're going to add a statement regarding ECMO. A respiratory therapist with specialized training and regular certification that's doing ECMO may receive an order to administer blood. And that's basically the kind of set. It may be 2 sentences in that we're going to add to the rule. Unless you think we ought to create a certification and track it. And I'm not interested in doing that unless you really think it's important.
No.
No, I don't think it needs to be, I don't think it needs to be tracked. And again, I don't have each of the facilities rules of who gets to play and who don't. But if I had to be a betting woman, I'd tell you every last one of them has the ELSO certification and undergo annual, if not more frequent, depending on how much they're doing ECMO training in a wet lab. And like I said, this has been going on since the 90s, at least in the New Orleans area.
We do not have, unfortunately, the advisory committee for perfusionists died. And despite our better attempts over the last 24 months to recreate an advisory committee, the governor has never appointed anybody. So we don't have an advisory committee. And so, but I will look into making sure that that's not going to cause a big stink with the perfusionists. But again, I think the real issue here is if they're trained to do it and they're doing it, what's the problem of taking an order to give the blood through the ECMO pump? If you think it's a problem, tell us. If not, we can go ahead and proceed on. But understand that just understand that if we start tomorrow, we're going to be lucky if we get it done in 6 months. Okay, that's just the way rule process is.
So my question, so the question is going to come up. If we start tomorrow, it'll take 6 months. Are you going to send out a statement to all these hospitals that say RTs cannot set pump, or just at the moment they cannot?
At the moment, right now, they cannot until and then we'll have the rule. And let me tell you why, okay? I assure you, trust me when I say this, there is going to be somebody who thinks this is an expansion of your privileges, scope creep, and is going to object to this, okay? While as benign as it appears, trust me, somebody will complain. There'll be a couple of comments that we have to address in the rulemaking process. So no, we're not going to do it until the rulemaking process is complete. Because I don't want to set us up for failure.
So what you're saying is we're not going to do anything till the rule is complete. So
right.
what is right now is.
Right. They may not at this particular moment in time, but on the recommendation of the advisory committee, the board and the staff are going to undertake a new rule proposal, and that process will begin once what has to happen, just so you'll understand, is Ms. Wilton and I will, or Ms. Lauren and I will draft a rule. I'll run it by Raymond, make sure he's happy with it, gets his imprimatur, we'll present it to the board. The board says, okay, we'll start, we'll give a notice of intent. that opens up a period of comment. And I can tell you that there'll probably be somebody who thinks that that's a problem. Could be the Board of Nursing, who knows who it is, okay? We just don't know. But I can assure you, somebody will probably think that we're jumping into their rice bowl, okay? And there'll be some people that object. Having said that, that after the notice of intent, there's 35 days for public comment. It will take the public comment and either modify the rule or send it on with the public comment to the AG's office, but make sure it's not antitrust. And then when it comes back, we do notice of final intent, and then there's an opportunity. Those same people that didn't like it can say, well, they ignored us. I want to go to an oversight hearing. And then they go to an oversight hearing, and the health and welfare will say, why did you do this? And we'll all go up there and explain to them why. And then they'll say, okay, we think that's okay, or we think it's not okay. And if that passes, then the governor approves it. Then we'll put it in as part of the rule and send it out that everybody can do it. Lauren, did I miss any basic steps?
Nope, you got it.
Okay, good.
Can we also include amongst the setup the difference between an ECMO specialist in terms of what they can do and a perfusionist and what they can do?
Well, I have some members in the perfusion committee that I'm pretty close to, and I'm gonna work with them to make sure we don't step on anybody's toes and cause any stink. Trust me, Dr. Hugo.
Because I agree with
Okay.
you, the conversation about scope creep and who's doing what, that's 100% going to happen, 1,000%.
All right, is everybody in favor with Dr. Van and the board moving forward with this rule change or rule addition? All righty. Is there any public comment, Doctor? Has anybody been listening to us?
There's nobody, if they listen and they haven't made a public comment, but we have no public
Okay.
comment.
Okay, do we have any reports from the licensing analyst supervisor?
No, we do not.
And I didn't see anything from investigations in our report, so I would assume that we don't have any executive session items.
We don't.
Okay. All righty. Our next meeting will be June the 15th at 9 o'clock.
All right.
Is there anything else the committee would like to say?
No, thanks, everyone.
All right, have a motion to adjourn.
I move we adjourn.
Thank you
Blake,
all very
second.
much for your input and your invite.
Dr. Ugo, second. All
Got
right,
it.
everybody. Have a
Everyone
great one.
have a great day.
See you later.
Bye.
Ah.
Oh, Raymond. Is he gone already?